I'm Claudine Wong, coming to you from the San Francisco Bay Area, and I'm joined now by Dr. Adam Schliffke. He's an anesthesiologist, also an assistant professor at Stanford University, and also the founder of the grassroots advocacy group, I can't even talk, group COVID Vent. Dr. Schliffke, thanks so much for joining us.
Thanks so much for having me, Claudine.
Okay, so let's talk about your background. You are an anesthesiologist by trade?
That's right. I trained at UCSF. I've been in clinical practice since 2007. I've been only at Stanford since July, but I joined Stanford so I could lead a lot of the digital health work that was happening at Stanford, where I had both a clinical appointment and I was actually a researcher. I was just about to start a clinical trial on a wearable sort of a DVT device, sort of digital health related, that came out of Stanford Biodesign. And before I was able to start the trial, I just had the IRB approved. Before I was able to start the trial, of course, the pandemic happened. And so that gave me an opportunity to actually do something new. And I kind of saw the writing on the wall, what was going to be necessary to help with the pandemic.
You know, and it's interesting because I've talked to lots of doctors about really kind of how this pandemic has kind of seeped into not only everyday life and projects and programs and things that they were starting on that they've now had to divert, but also how they kind of interpret, you know, really what's happening, the response, and how best to really help and change the way that we're responding to it and thinking about it. I mean, how much over the past few weeks, because really it changes day by day. I keep saying, you know, what was a great idea on Monday seems like a terrible idea on Wednesday, and we can't believe that we ever even suggested it. How has it kind of changed the way you look at medicine and how we're all, you know, dealing with this pandemic?
Well, to be honest, as difficult as it is today to see all the pain and suffering that is happening in this country and really throughout the world, the one piece of sort of opportunity and light that I see is really an opportunity for all of us to think about a system that we want and really redesign it. Everybody knew for many, many years that there were lots of difficult, perverse sort of incentives in the system. And now what I say is, like, the system was already broken, and this pandemic has sort of broken those fractures wide open. Right.
And so everything we've seen in supply chain or access
at
all of it.
At every level. I mean, if you look at physicians, right? Everyone talks about the burnout of physicians. 50% of physicians are burned out. Why is that? Because they don't feel support from their administration, right? They don't feel like they have any autonomy. They don't feel like what they went to medical school is what they're actually doing, because they feel like they feel all these perverse incentives, you know, firsthand. And so these things we're seeing very, very clearly in this epidemic. Why don't providers have the right equipment? Why are they being forced to do elective operations when there's limited equipment? Why are they putting their own lives at jeopardy by not having the provider equipment, et cetera? Like, there are a whole host of problems that we're seeing, like, right in front of our faces as a result of how broken the system is.
Right. So there becomes the water cooler talk, right? It switches, right, from the sitting around with doctors at a dinner and going, gosh, this is crazy. Why are we still putting up with this? Oh, it's just part of the system.
Exactly.
And then it switches into a different space of, well, why are we talking about this? And I think the pandemic has really spurred a lot of people to action in new ways, you know, and I think take for you to say, okay, I'm not gonna, you know, I'm sitting, I knew this was always an issue that I didn't like, but now I can't not do something and speak out about it.
So I am an entrepreneur at heart. I have been in digital health for 15 years. And a lot of people have complained about digital health because a lot of money has gone into designing these companies that work on some aspect of the healthcare system, but they really haven't moved the needle on true innovation in healthcare. That's at least my opinion. So I'm of the mindset that the way to design technology in medicine is to take a very specific need and design technology around that. A lot of the digital health companies that are out in public now are almost the opposite, where a tech company is trying to apply some cool technology for a need. I have worked very closely with Stanford Biodesign, and in fact, I was going to be the PI on a study for a company that came out of Stanford Biodesign. And so in this current pandemic, the need that I saw was the lack of critical care capacity in this country. And so on March 14th, I sat down at a computer and I wrote a 2-page document that was essentially two things. It was a call to action and a very high level operational plan for how you would convert non-ICU space into usable ICU critical care space. And from that, it turned into a movement. I have been uh, unbelievably proud of all the people that have contributed to this effort. We've raised absolutely no money. Every single person that is helping us is in it for all the right reasons. And I have to be honest, I have the best team that money cannot buy, because everyone has the right sort of mindset and true intentions. They're all trying to do something about the lack of critical care capacity in this country. And so it's really warmed my heart to see all this, even though it's been a very difficult time for everybody.
So it's been about 2 weeks. This is called COVID Vent, right?
Yeah.
And I know you describe it on your Twitter page as a multidisciplinary group with the goal of raising the bar on critical care capacity. How many members do you have? And is it all physicians, or is it just anyone who wants to join
Yeah.
in who may have an understanding of how to do this?
Yeah, it's anybody. Everybody is welcome. For several weeks now, we've done town halls. First, we were doing them one time a day. Then we expanded to 2 times a day. Now we're back to 1 time a day. But it's really an opportunity. The way that I've always viewed it is more of an open sort of collaboration, right? Bringing everybody to the table so that we can figure out how to do something that's never been done before, right? Like, we've never, as far as I know, in this country, been forced to repurpose space that was used for one purpose and use it as critical care space. I mean, you can almost think of, if you take the surgery centers as an example, you could think of it as almost a mini hospital, right? Like a pop-up mini hospital. The surgery centers have oxygen piped in, they have anesthesia machines, they have medical supplies, they have equipment, they have providers that are on the sidelines not working. And so now you're repurposing all those resources to deliver critical care capacity, which a couple weeks ago wasn't even available.
Okay, so let's get specific for people who, not doctors, not studying this, not understanding this. I mean, we've seen the Navy ships now in New York and in California.
Yeah.
There to provide beds. In Detroit, they're turning the convention center. They've canceled the auto show, which has millions of visitors every year, and they're putting beds in there. Are you talking about that? But that's beds, right? It's beds 6 feet apart, and saying if you're not really, you don't have COVID, you can come in here, or you do have COVID, put you in there.
Let me push back a little bit here, because when you think of care of COVID patients, there are things that you can do at home. There are things you can do in the hospital, like as just a hospital patient. And then there are things you need to do when the patient gets very sick, right? And those things that you need are very different at every level. So let me just suggest something, that instead of putting 1,000 beds in a facility where patients might be spreading disease, why not take care of them at home, right? So if you could have a system where you had 24/7 data from the patient about their respiratory rate, their oxygenation, their heart rate, their temperature, and on top of that, you have sort of a dashboard that takes all that information and alerts a provider if they need to be alerted to contact the patient to send them to the hospital. Why not take care of patients at home so that they're not spreading infection, and so they're at home, not taking up a very limited resource, which is hospital beds.
But let me ask you this, because all that sounds great, right? But I'm a news anchor who is now anchoring from home, and setting this all up. I mean, if you watch, has been, like reinventing the wheel, and all of a sudden I'm doing things that normally I'd have people who knew how to set that up. So digital health, I would imagine the ideal, right? You'd bring someone in to be able to settle this stuff, to make sure it's collecting the data properly and doing all those things. But now you're going to ask someone who maybe can't even figure out how to, check their Wi-Fi to set up something, and it seems like a good idea, but how do you put that into life?
Yeah, that's a fantastic question, but the technology already exists that's essentially turnkey. All you really need is a small sensor, which is provided by some companies, and a smartphone. The rest, the complicated sort of analysis, that's done on the other end, right? That's done by professionals. So we've always been of the opinion that there are low cost, low technology solutions to very difficult problems in healthcare. And that's what excites me about sort of the next generation of digital health. It's not taking care of sore throats and urinary tract infections. It's actually taking care of very sick, chronically ill patients at home using cool technology that is very simple to use, that is managed by professionals when it's necessary.
Now, I've seen, technology similar to what you're talking about. I've done a story on, a heart monitor for heart patients so they can detect and study this before, but it was still in a study, right? And so they had
So
a handful of patients at UCSF, and then they were
yeah,
University of Georgia, but we're ways out. Is this that you're
yeah.
talking about now, saying the next time we should be prepared for this, or you want to start shipping out sensors right now to anyone who says they might be feeling bad?
So let me paint a picture for you. So it's a great question. This the device that I'm specifically referring to, I don't want to talk about the company, but like it's FDA approved, and the FDA has made exemptions for COVID because of the pandemic, meaning it was FDA approved for one purpose, and now it's being repurposed for taking care of potentially COVID positive patients, right?
Okay.
So it's been through the FDA, it's been validated and tested, and on top of that, it's already being done. So the picture is this: instead of a patient going to an emergency room, they pick up the device and they're sent home. So you've seen pictures of lines at New York, for instance, where people
Yeah.
are waiting 12 hours to get in. You completely decompress the emergency rooms because a lot of the triaging can be done right up front, and then they're sent home and you're monitoring them. And when they get sick enough that they need to be sent to the hospital, you can act right away and send them to the hospital. So you've just solved that sort of flow problem with the emergency rooms using a very low cost solution that's very easy to
Is
implement.
there a system set up for a doctor to receive it, right? You got both sides, right? You can have a drive-through, pick up your sensor site, but if you don't have enough people to analyze the data, then it doesn't work either.
Right. That's all done. It's all been done. So we have people so for instance, I just mentioned to you, where it's happening is Intermountain Health. So they have nurses that sit in a room and they look at the data and they're alerted when there are problems with the data, and they're the ones that act. So even though there's some analysis of the data, at the end of the day, there are still providers who are providing oversight of all that information. So it's different than Fitbit. Fitbit or a pedometer is always collecting data, but that data is not shared with physicians, right? It's a direct-to-consumer device. People buy the device, and then they might share it with their doctor. This is sold to the hospitals. So the hospitals are engaged, and they're potentially providing providers, or our sort of grassroots movement is providing providers. And so there's oversight at every sort of step.
So Intermountain Health is located where?
Uh, it's somewhere like, I think it's in Denver or somewhere
Yeah.
on
Okay.
the West
And how
Coast.
many patients
Yeah.
are actually using this right now?
So I don't know how many are using it. I think they're just starting it, but I can tell you, they're going to be implementing it sort of system wide. I believe that you may have to check on that
Yeah.
information. I don't know if that's exactly be true, but
Well, I mean, I think as it becomes okay, that sounds like, especially if you, I would imagine if you called the doctor in New York right now and said, "Hey, you want to try this?" They'd be like, "You know what? I'm barely getting through my day here.
well,
I don't, that
you're
sounds like
right.
a great idea, but I can't do
You're
that."
right. So they need a turnkey solution that they don't have to worry about, right? And so that is part of what we're working on, actually. So so again, I've been in this space for 15 years. I know all the companies that are working on solutions like this. So what we've done is we're not developing anything out of the box. We're taking the best in class technology and putting it all together to make this possible.
And you know so what's the hurdle in terms of, some people say, "Oh, is this just a business opportunity, or is this really going to happen? Do you really have the, because I tell you, as a reporter, I see a lot of great little technology things coming in the digital space, especially when it talks to health in terms of
Yeah.
how to do it, and then it becomes um is that going to work,
Yeah.
or is that just a great idea but it
Yeah.
doesn't really, like.
Well, right. So one, it has to be like, can you do what you claim you can do, right? So the idea here is that you're preventing patients from going to the hospital until they get really sick. So can you do that, right? And so really it becomes winning over the hearts and minds of the executives in these hospital systems that are suffering as a result of being inundated with potentially COVID positive patients in their emergency rooms.
And are they listening? I mean, are you struggling with that? Are they saying,
I mean,
are they pushing
we're
back?
just at the beginning of speaking with them, but I strongly believe that there's a huge appetite both on the increasing critical care capacity and in really taking patients away from the hospital and sending them home, because there just isn't space for all these patients that are going to continue to come.
Yeah. Okay. Let's talk about that critical care capacity too, because you've got some also ideas on that in terms of, one of the things you said was elective surgeries still going on, and a lot of people
Yeah.
going in there for other reasons. And that seems kind of crazy because depending on where you are, right? If you are in New York, I don't think any of that's still happening. But if you are
Well,
in other parts of the country, maybe they are, or is it still happening?
Well, no, it is still happening. That's the shocking part of all of this. And the reason it's still happening is sort of multifold. That if you think about the way that hospitals make money and surgery centers make money, it's doing operations, right? We still live in a mostly fee-for-service healthcare system in this country. And so even though we know it's almost immoral to be operating when there are such limited resources and where patients are potentially carrying, asymptomatic COVID. They're doing it because they're financially incentivized to do it, and the providers, the anesthesiologists, the surgeons are up in arms. They're extremely upset, but they have no control over what the administration is pushing them to do. CMS recently came out with recommendations, not enforceable, but recommendations about what is okay to do, surgery for and what is not okay. But because there is no teeth to the recommendations, they're not being followed. And I can tell you, I have many friends that are anesthesiologists who are in the middle of these conversations between the surgeons and the anesthesiologists on the front lines. The anesthesiologists are saying, like, we shouldn't be doing this surgery. It's completely elective. It's inappropriate. And the surgeons are saying, you know what? You're right, but the administration is telling me we have to fill our operating rooms. And so it's a very difficult situation. I wrote an op-ed a couple days ago that was posted in the USA Today. In that op-ed, I basically said that half of the surgery centers in New York are still business as usual. So you just mentioned New York. New York is one of the hot spots in this country.
Right?
They have every reason. They have every reason to be on the right side of this and not doing surgery, and yet they're still doing surgery.
So where does it need to be, need to change if administrators, I mean, is this where you think, the governor should step in and say, we
Yeah.
are banning it? And because we've seen that in, no schools, no, I mean, this government position of saying, where do we step in and where do people just take, that responsibility themselves? When do surgeons tell their patients, can they tell their patients, I'm not going to do that surgery? They do have control.
Right.
They walk into that operating room where they don't.
No, the surgeons are put in the middle of this too, right? Because if they tell a patient that they can't have surgery and they're not backed up by both their administration and like the government, right? Then they're liable, right? I mean, the patients can turn around and say, like, you didn't operate on me, you should have operated on me. So where the only place this can change is either at a government's executive order or at the federal government, like CMS.
Let's say about if they do change it, how much does that change in terms of, I mean, we know it changes in terms of supplies, right? Masks, it changes in terms of staff, it changes in terms of, I know you wanted to turn ORs into ICUs. I mean, it changes in terms of what we can use that space for. Because I mean, I think if we're bringing Navy ships in, we are preparing for not having enough beds.
There are 100,000 anesthesia machines available today that are not being used. So I don't know if you've seen the demands for ventilators, for anesthesia machines or ventilators. Some people have predicted that at the height of our surge, we will need 1 million ventilators and anesthesia machines. That capacity simply does not exist today. And I don't know, even with manufacturing, and the government is encouraging Ford and other companies to manufacture, even with 24/7 manufacturing, we're still not going to have enough ventilators. So if you repurpose all the operating rooms that don't require emergency surgery, the intensive care units, the endo suites, the surgery centers, you can add today almost doubling the ventilator capacity. 100,000 plus the 150,000 exists. So you'll have 250,000 anesthesia machines and ventilators.
So just like you said, trying to talk to the administrators of these hospitals to get them on board with digital health, where are you in terms of, because, from the layperson's standpoint, I'm sitting here saying, we keep reporting on the fact that there's not enough equipment. You
Yeah.
have this solution. Where is your big pushback, and in terms of your group saying to these hospitals and these surgery centers, why don't we do this? Are you not getting anywhere? Are you just kind
No,
of?
no, it's more advocacy than anything else. So we have approached governors of states. We've been proud that some of our work has actually been adopted by some of the governors, and they've adopted executive orders. But I would contend that even the executive orders don't necessarily go far enough. So there are two ways to do this. One is on the state side, right, with executive orders. The other is with reimbursement. So everybody knows of all the perverse incentives of this system. What if we rewarded the good surgery centers, the surgery centers that decide to help in this crisis and stop surgery and repurpose their space for critical care, as an example? And what if we penalize the bad actors, right? The surgery centers that were still operating business as usual, they don't need to get reimbursement at all. CMS has that power. They control, I think, 50% of the spend in this country. So if they adopted what our advocacy, our policy briefs are suggesting, like, we could really completely change the system for the better.
And so you want state lawmakers and lawmakers on Capitol Hill to start addressing this at this state, federal, probably the federal level, to make this an issue that you
Yeah, we're
so hard for, I guess.
we're approaching both because we're hopeful that the federal government will do it, but we're not confident, and so we have taken the tact of approaching both the states and the federal government, and we hope that eventually either all the states decide to go one way or the federal government comes out with changes in reimbursement.
I'm curious which states have been the most open, or which areas that you've found the most leeway
Yeah,
that
so
you're getting.
so New York, Illinois, California. There are a couple others. I don't remember where the executive orders have been initiated, but any state that has written an executive order around elective surgery should be applauded.
Mhm.
I want to be very clear, though. I don't think today we go far enough, because still, even with the executive orders, and it's not the fault of the states, but even with the executive orders, there is too much wiggle room in the system. And so again, the surgeons and the anesthesiologists are put in the middle of these situations, and they're dealing with it on a daily basis.
Yeah, I mean, it is a difficult situation. When you look around the world, though, I mean, usually we because other countries have dealt with this before. Are you seeing anything that they're doing, in Italy that has worked that you're saying that we should do as well as any of this model, or is this new territory that?
Well, it's new because of the way our system is set up. So, the reimbursement is different in the US than in many other countries, but even more importantly, independently owned and run surgery centers they're not tied to a hospital, right? Typically, they're owned by physicians or businesses. And so it's a completely different sort of economic incentive structure for those surgery centers. And the problem with treating COVID positive patients, or really hospital-based patients at all, is they don't bring a lot of money to the hospital. That's sort of the dirty secret. And so the surgery centers really don't have an interest in caring for these patients with the way that reimbursement is currently set up. And that's why we're asking for changes in the way reimbursement is done, so that they will have the incentive to take care of these patients.
Yeah, I'm curious, you were in digital health for, 15 years, because that's where you feel like the future is. And obviously you still believe that that is a huge impact. But how has this whole process changed you, in general, as a physician, looking out and interacting with people? Because this pandemic has certainly changed the way we all look at the things we're doing and the world around us.
Yeah, I mean, listen, there's a lot of money has been invested in digital health. As far as I'm concerned, we haven't really seen the promise of what digital health was supposed to be. What this pandemic has enabled is us to design a system that we want, and really that's what we're in the process of doing, using digital health tools. So you're right, I have been in this space for a long time, but I've been thinking about all the different levers in the healthcare system that we can push or pull to take all these great companies and put them together and create a system that works. And so that's really what we're in the process of doing.
So in terms of optimism, I mean, we look ahead and it's a scary, brave new world, right? We'll look at our lives and how we kind of ran through things pre-corona and post-corona.
Yeah,
People make that 9/11 comparison where, I have to remind myself after 9/11, I wondered if I'd ever feel safe again. And I have that
yeah,
feeling again, right? Will I ever be able to hug someone or
yeah,
greet an old friend in the grocery store and not feel this fear for the unknown and this way that we'll live in terms of how you think what you're talking about when we're talking about flattening the curve. I mean, there's some things we wait for, right? We wait for the vaccine, we wait for medicines that work, we wait for, some sign that maybe there's some herd immunity within us all that prevents it from spreading further. How impactful do you think the things, I mean, obviously turning an OR into an ICU could help save lives if you can treat the people who need to be treated and you can get them the ventilator that they need, um, and if people aren't going into the hospitals, but
yeah.
what's the
I'm very hopeful. So to answer your question, I have always been super skeptical about digital health in general, and now I'm hopeful. I'm hopeful because this pandemic has turned everything on its head. I have some of the biggest companies in the world, biggest technology medical device companies in the world, coming to me asking me to partner with them. 2 weeks ago, that would have never been possible. I would have never been able to speak to those people. And so I have people texting me, telling me, like, this is our opportunity, right? Like, let's make a system that works for everybody. Forget about the special interests, forget about the lobbies, forget about the hospital administrators. Like, let's take the physicians and the patients and like design a system that we want, for our future, and one that will actually be able to deal with things like the pandemic, which we're seeing it has no ability to deal with right now.
So 2 weeks ago, this wasn't even something that really you could even consider. Where does it look? What do you look like in 2 weeks from now?
Yeah, I mean, right now we're a team of about 20 people, honestly. I think in 2 weeks we have a very large announcement of a partnership with a very big company. And I think on the remote patient monitoring side, we're implementing throughout the country. That's where I think we'll be in 2 weeks.
And where do you think the country will be?
Well, that's an open question. I'm
Yeah.
hopeful that people will stay at home, that they will do the things that they know they need to be doing to prevent the spread of this infection. I'm afraid that places like New York and LA there's gonna be a lot of suffering people. A lot of people are gonna die, unfortunately. I know that the hospitals already in New York are overwhelmed. I'm scared for the future of New York, I have to be honest.
Yeah, I'm scared. I'm scared for them. I'm scared for all the other states who are just now walking down the path that certainly we have seen in other
Well,
states.
so I would say to that though, now is the time to prepare, right? A
Mhm.
couple months ago, if we would have handled this differently, we wouldn't be in this situation. So maybe maybe New York is too far. I don't know. I think we can still help them. But let's just say, let's let's look at the areas of the country where the surge we know is going to happen and hasn't happened yet, and let's prepare those places. Let's do the conversions now of the operating rooms and of the space that is an ICU space in the ICUs, right? Like if we were prepared, we could save many more lives, I believe.
And because you're at Stanford, is the Bay Area, how do you think locally? I mean, you talked about your devices being, some in a different state, but you're in a place of Silicon Valley where usually technology and innovation is embraced with open arms. At least that's the reputation.
That is the reputation, but the challenge about innovation in large academic medical centers is that the most hospitals are very slow to move because of all the regulatory hurdles and requirements and all the legal ramifications. And so if you're a big institution with a great name and reputation, you're very hesitant to do anything sort of outside of the box thinking, because you really, like, you have to protect the brand, the reputation of the hospital or the medical center or the system.
So does it take, like anything, one big hospital system starts it, and then once that ball starts
Yeah,
rolling down the hill, then everyone else says, and if every other surgery center has converted and you're the only ones, no one wants to be that
exactly.
one, and then it becomes the snowball gets bigger.
That's exactly right, and that's why why everything has developed momentum as a result of what we've done. I mean, again, it started with an idea. It started with a two-page paper. now we have 20 sort of full-time people working on this. We have a group of maybe 100 outside who are advocating for us. We have a whole 30-page operational plan for how to think about converting these spaces. We have developed these interesting relationships with these big medical device and tech companies. And like I said, it wouldn't have been possible a couple weeks ago, and it's actually happening. So I'm excited to partner with these companies that have the right intention, right? Not every company does, but there are companies that come from the right place, and they want to do right by society and improve the care we're delivering in the situation that's going on in these states. And so I'm confident that with the right partners, we can actually solve a lot of these problems.
Do you find too that, I mean, whether or not we wanted to rethink of all these things and think about new ways of doing them, no one, in whatever industry they're in right now has a choice.
Right. Yeah, I don't think we have a choice. I know that many of my friends who are working on also solving needs, like it's desperate times. I mean, I have to tell you, I don't sleep a lot. I'm always seeing my friends' postings on, Twitter, etc., and just like all the pain, and knowing in my heart that not that I've figured everything out, but I do have some of it figured out, and I want to share the opportunity that I see with those people so that we can like really improve the care that's being delivered in these communities.
And sharing of ideas and information, never a bad thing. And certainly we hope that out of this horrible time, we learn new ways to look at our world and
Yeah,
better care for each other. All right.
yeah.
Dr. Adam Schliffke, thank you so much. It's very interesting to hear about all that you have on the horizon. And we love in a time that we're talking about problems that we can talk about solutions, because certainly that changes the conversation.
Yeah, thanks. It's been an honor. Thank you.
Thank you. All right. And you can get more information at coronavirusnow.com. Thanks so much for joining us.